thank you for that very kind introduction and the opportunity to speak here this evening. I actually was here before we opened the Cancer Assessment Clinic several years ago, and was talking about if anybody was around then. I remember Ted. Yeah. And so it is nice to have the opportunity to come back. I'm the manager of the Prostate Cancer Assessment Clinic, and I'm often behind the scenes and don't have the opportunity to speak to patients always directly. So this is a real treat for me. Marian and I did present this focusing on communication, this presentation, and we're very proud to win this award, which is why we could afford a little bit of high-tech stuff at the end. We know, and you know better than I do, that prostate cancer is a very common cancer in Canada. That's why one of the reasons we really wanted to focus on it at the Ottawa Hospital. I think the latest statistic is 1 in 7 Canadian men will develop prostate cancer during their lifetime. And we know it's a very disrupting and change and often a crisis in lives of men, families, and really warranted some attention, I think, from many people in starting with the Prostate Cancer Assessment Clinic and recognizing that phase and that intake of coming in was a very stressful one, and we needed to do a better job around that. So we really wanted to focus on the nursing piece of how we contribute at the Cancer Assessment Clinic. And we were really talking about communication and recognize that communication was between a nurse with the patient and their family. Also nursing as an integral role of the multidisciplinary team that's working within the Cancer Assessment Clinic. We have urologists, radiologists, technologists, social work and nursing, and to name a few. And then we really enjoy and very interested in working with community partners and making that, we can't be everything in hospitals to everybody, but trying to link with our community partners was very, very important to us. I think the other unique thing about prostate cancer, and as you heard in my introduction, I also manage other areas, but you know, there is some choices in prostate cancer and a lot of decisions to be made, and was sometimes in a fairly short length of time. So you know all of these and a lot better than I do probably. So, but just it's fairly unique, I think, amongst some of the cancers that I manage in the prostate cancer assessment, in the Cancer Assessment Clinic. So I just wanted to focus a little bit on the background, the process redesign, what we did and how we did it, just briefly, some of our nurse-led initiatives, and then some of our future initiatives that we're going to do. As was already said, we opened the actual Cancer Assessment Clinic that the Aegis family helped to support in January 2007, so we're I think in just 2 days, we've been open for 5 years, so which is quite an accomplishment. Prostate was the third one we got up and going, and actually opened it in May 2008. So this we've meant for men to come in for an evaluation assessment for prostate cancer, not for men diagnosed already, but to bring people in and try to get people through in a better system than what we had before. So we had a lot of impetus for change, and if people can remember, and we've discussed, when I started to get involved in this, historically at the Ottawa Hospital, just for trust biopsy, the wait time was 8 to 12 weeks. And I think most of the time it was kind of closer to 12 weeks whenever we really took a look at it. We knew that that was too long. We knew that there was a lot of anxiety and distress waiting. And, you know, looking at our data, 2/3 of the men do not have prostate cancer, but even to be told that, too long a wait. We know that it delayed the diagnosis and treatment planning. The urologists were not happy with the time, wanted something done. And we knew that we had fragmented care. We work very much in silos at times because we're a large organization. So the diagnostic imaging people and the people, we had to come together, and how were we going to do that and how were we going to improve? We really looked at our current state, collected a lot of data. We looked at how what we did well, what wasn't so great, and then we really tried to review processes and redesign how we do things. And overall, really what we're trying to do is bring the team to the patient, recognize and make wait time targets, recognize that the patients need a multidisciplinary team, who's the right person at the right time, and then try to put some technology in and how we could improve flow, have some timely access to data, and then talk to patients and try to get some experiences how we can improve. We created a centralized access system. We have the majority of the urologists at the Ottawa Hospital working up there, plus other health professionals. We wanted to do a single point of access. We really tried to coordinate with our diagnostic imaging team, radiologists, administrators of that too, around intake, and trying to really look about how can we either protect spots or targets and all those things. So it took us quite a while to look at how to improve it, and we're still working on some of those things. So, we redefined with the urologist, the referral indicators. We wanted to make it pretty broad. We didn't want to say, well, get all these things done and then we can see you. We wanted to really try to bring people in. We wanted to bring, we standardized and systemized how physicians work, right? Instead of physician A, B, C doing something quite differently, and we took over sort of the flow and the scheduling of all of that, which is challenging, but I think has worked fairly well. We put target of 2 weeks for trust biopsy, and then bring people back for a follow-up visit. So that's a very simple, we have a very complex prostate process map, but this is sort of a simpler version in the end. So some of our nurse-led initiatives around that, we worked and developed with members' help here, our patient information guide and personal record that we put together, quite different from the one we have in other disease sites. I think they told us at one point, if I remember correctly, let's just stick to the facts, no flowers. We really worked on our trust biopsy care for pre and post care and had nursing in that, where traditionally it was just done by diagnostic imaging. We developed patient resources, community links, and implemented decision aid and surgical preoperative education sessions. We have to fundraise every year for this, so we really appreciate feedback on it, what works for people, what doesn't. We're really trying to focus at the Ottawa Hospital on providing patient-centered care now, so I do go out and talk to patients, and if I see they have this, I always ask them, are you using it? Does it work? We're always hoping people use this to help track and to use it how they want, right? It's a personal record with some information, credible websites, resources, but it's meant for your own use. So we are going to be looking at these regularly. We try to keep up to date. And if anybody has any great feedback, and even after this, we always appreciate it. So we're always trying to make things. So, okay, Marian.